Hello, everyone. Welcome. We're going to get started in a couple of minutes. So get comfy, get cozy. We've got a lot to talk about, but thanks for being with us, and we will get started in just a moment. Okay, Scott, the floor is yours.
Okay, great. Thank you, Sumaira. Good morning, afternoon, or evening, depending on where you are in the world. And thank you for joining us today. So, today we have a webinar on understanding clinical trials for MOGAD and the importance of patient participation. Just a reminder, this session is being recorded and will be published online at a later date. So, if you have to nip out, no worries, it will be going up online soon. And this program is made possible with support by UCB. So thank you to them. And our featured experts for today are Dr. Saif Huda, Dr. Katharina Fink, and Dr. Silvia Messina. So, and one more thing that I need to mention is um, if you want to set up the closed caption translations, if you go to the bottom of your screen, there's an option which says show captions. It's a box with a CC in it. If you open that and click the translation, you can translate this session into whatever language you like. And I think that's all housekeeping things.
Yeah, but Scott, tell us about you.
Oh,
We're
yeah,
dying.
about me.
Yeah.
I forgot. Yeah, I need to tell you about me. So, hello everyone. I'm Scott Tarpey, the moderator of this session and the founder of mymyelitis, which is an online resource dedicated to helping people with Morgan disease. So, my path to being here started in March 2020, where unfortunately I was struck down by transverse myelitis right in the middle of my accounting exams, which was not very fun. So, in the course of 4 days, I went from having a small numb spot in my lower back that spread around my waist and up my side, then started having bladder problems, and then finally was unable to walk. Thankfully, I was treated very well at the National Health Service here in the UK, Leeds Teaching Hospitals. My neurologist actually predicted I had Morgan disease before it came back, the blood test came back as being positive. So my treatment was great and I made a pretty good recovery. Um, but during my recovery, I was spending a lot of time researching about this condition. And this is where I came across some of the non-profit organizations, such as the Sumaira Foundation, as well as lots of research papers, including some from the experts we have here. And thank you so much. That was very useful. Um, and as a result of that, I created My Myelitis, which was originally a blog to track my recovery, making sure I was doing the physical therapy required, making sure I was keeping up on medications. Um, but then eventually I decided to expand that a bit more to help other people going through the same journey. So I think that should be good. Very happy to be moderating this today, and thank you, Samira, for inviting me to do so. Um, and I think that is good to go to the first expert presentation, which I believe is Dr. Saif Huda. Yes, over to
Thanks very
you.
much. Thank you. Slides visible to you, Scott? Lovely.
Yep, all good.
Scott, thanks so much for telling us your story and for moderating. And Samara, thank you for the invitation to UCB for sponsoring this. I'm just going to move that window so I can see my slides properly. There we go. So my name's Saif. I lead the NMO, MOGAD and Autoimmune Neurology Service in Liverpool, north of England. And I want to thank you for being here today. I know being diagnosed with something like MOGAD or supporting someone who has this can feel very overwhelming at times. My aim is to try and break down what this condition is with my colleagues and talk about what symptoms it causes, and give us a bit of an understanding about its course over time. Does not want to change my slides. There we go. That's good. So yeah, I'm part of a ragtag team today, and but to me, first up, talk about presentation symptoms and the course of MOGAD, and then after me will be my esteemed colleagues, Dr. Katharina Fink and Dr. Silvia Messina, who will be covering diagnosis treatments, and then the COSMOG trial and clinical trials. So I'm going to tell you some things that you probably already know, but I'll just go over them just in case. So what is MOGAD? Well, what is MOG? Well, MOG stands for myelin oligodendrocyte glycoprotein. And that's why we call it MOG, because it's a bit of a mouthful. And it's a protein. It looks a bit like that. And proteins are kind of the building blocks of life. And they sit on the surface, well, MOG sits within the surface of myelin, and it's expressed, it's present in the brain, the eyes, and the spinal cord. And when we talk about myelin, we're talking about this electrical wiring and the insulation sheath that surrounds it that allows that fast conduction of electrical impulses, because our brains are just one big electrical circuit, and we need wiring to connect us so that my hand can move in this way when my brain wants it to without me thinking about it in a rapid manner. And that rapid communication is made possible by this electrical wiring, but importantly by this insulation, and MOG sits within that. So in MOGAD, in MOG antibodies, when they are produced, they target MOG, and what they cause is inflammation and demyelination. And by demyelination, this is my analogy is that we've got our iPhone lightning cable here, and it's frayed. The myelin sheath, the insulation has been damaged, the integrity of it's gone, and so the charging of that phone is not as quick, the communication isn't as fast around the body, and that can lead to symptoms like weakness and blurred vision. But I think it's also important to talk about what MOGAD is not. And these may sound obvious, but actually experts throughout the world were confused by this condition for decades. We've known about MOG for years and years and years, but we didn't have it quite right. And we used to think MOG was something that we see in multiple sclerosis, but it is not multiple sclerosis. It may share some features with it, but it is a completely different disease. We, up until, I suppose, even 2023, some people were still calling MOGAD part of NMO. But we recognize now that it is a completely separate disease. In fact, we discovered MOGAD from cases of NMO that we didn't find antibodies in. So it is not NMO, it's not multiple sclerosis, it's a distinct condition with its own disease patterns, its own unique treatment responses, and its own unique outcomes. So how does MOGAD present? Well, attacks come and go. It's a relapsing, remitting condition. So when you have it, you know about it, but when you don't have it, things are pretty quiet. But when things do occur, they usually come on quite quickly, over hours to days. So not as quick as a stroke, but also not as slow as something else, something slower. It's hours to days typically. And it can be mild in its presentation or severe, but generally, compared to some of the other conditions that my colleagues and I deal with, it's on the milder end of the spectrum, but not always, and it affects the places where myelin is present. So the eyes, when we call that optic neuritis, if it affects the optic nerves, the spinal cord, when it causes transverse myelitis. The attacks can also occur in the brainstem and cerebellum. I'll talk a bit about ADEM as well, and something called cerebral cortical encephalitis, or CCE. So how does MOGAD present in the eyes? So we talked about optic neuritis, and this is typically someone will come to the clinic and they'll say, you know, I've got painful vision. My eye hurts when I move it around, and my vision's a little bit blurred. Things aren't as clear in my left eye as they are in my right eye. And colors, especially red, look a bit washed out in my affected eye. And sometimes they might describe what we call a scotoma, which is just a fancy way of saying an enlarged blind spot. That thing that when you're driving, you look over your shoulder and check, that can be enlarged sometimes in people with optic neuritis as the only finding. And sometimes it can just be painful eye movements and nothing else. When it affects the spinal cord, we call it transverse myelitis, and this typically causes weakness and numbness of the arms or legs or both, and this often is accompanied by urinary symptoms. I just realized how dark it is in the back of my screen. Sorry, the light above me. It broke yesterday, and I'm not the handiest of people, so I haven't fixed it quite just yet. But I'll try and get a bit of light there. Okay, it looks like I'm telling a ghost story. Right. So we grade mobility in the clinic using a score that was designed for MS, but we use it in MOGAD. It would be great to have our own scores for MOGAD, but it's something called the EDSS score. And we can rate that from someone who's able to sprint and run normally. And when transverse myelitis affects someone, it can just cause an inability to run as quickly in the mildest of cases. But of course, in the most severe of cases, it will cause the need for one-sided walking assistance, maybe two-sided walking assistance, and in really severe cases, loss completely of the ability to walk or the requirements of a wheelchair. But again, these conditions, particularly MOGAD, is very, very steroid responsive if we get in there quickly. So how does MOGAD present in the brainstem and the cerebellum? So this is where the brainstem and cerebellum are, the base of the brain, the hindbrain. And they're very important, these structures, for balance and coordination. Also for speech, the speech might become slurred. It can also affect swallowing because they're very linked, speech and swallowing. And it also is involved in the yoking of eye movements, the control of eye movements. You know, those eyes aren't moving in synchrony, we can get double vision. And again, we can experience weakness with brainstem and cerebellum involvement. I mentioned ADEM, and I use the term ADEM because it's another long acronym like MOG. So that ADEM stands for acute disseminated encephalomyelitis. But it's easier if we break it down. So acute in medical terms doesn't mean severe, it means quick onset. It means it comes on quite quickly, which we already know now that that's how MOGAD presents quite quickly. And disseminated means it's in different places, and that reflects the different parts of the body that can be affected. The entire central nervous system can be affected in ADEM. So all the things that we've already talked about, the brain, which can cause stroke-like symptoms, the brainstem, the cerebellum, the eyes, the spinal cord, and it's often accompanied by drowsiness. So the encephalo kind of implies the drowsiness bit, and the myelitis, you're already experts at that now, that's the spinal cord inflammation. This is extremely common in kids. Around 40% of all cases of ADEM are related to MOG antibodies. It's extremely common. In fact, MOG antibodies are super common in kids, full stop. So we're always on the lookout for that, especially high index of suspicion in children. And then there's another rarer presentation that we sometimes see a bit more commonly in other parts of the world, but we do see it here as well. We've seen several cases here of cortical encephalitis. And this is important for neurologists to be aware of because it can present like infective forms of encephalitis or other autoimmune types, and we have to have our heads in a swivel and be thinking about that. And encephalitis is an inflammation of the lining of the brain, and that causes irritation, and that can result in seizures, but also prominent confusion. And again, because it affects the brain, it can cause stroke-like symptoms. So what symptoms do people experience? They're kind of a mishmash of what I've mentioned already, and some of these may persist after the attacks. Visual loss, double vision. I'd add to that headache. Headaches are quite common, just anyway, but after MOGAD optic neuritis, we see headaches a bit too. Weakness in the arms and legs, numbness and tingling, loss of clear control of the waterworks and the bowels, fatigue, that's very common to all neuroinflammatory conditions, and MOGAD is no exception. Pain and seizures. Sometimes after the encephalitis episodes, people can develop epilepsy as well. And what about the long-term course of MOGAD? So as I mentioned, this is a relapsing remitting condition. So you have attacks, and then in between attacks, things are pretty stable, and then another attack potentially. But some people just have one attack, and we call that monophasic disease. And you kind of have to watch people for a while to call it monophasic. You can't call it after a year. It needs to be several years of stability before we say, oh, it's definitely monophasic. But then other people have relapsing disease. And depending on what papers you read, the numbers are, somewhere between 30 to 50% of people who have relapsing disease. But what we do see is that in people whose MOG antibodies remain positive, or if the titers go up very quickly and very significantly, that can sometimes indicate there's a slightly higher risk of an attack. But I have lots of patients as well who have antibodies that hang around and they're absolutely fine off treatment too. So it's not always definite. And one of the things that we do see is when the antibodies go away, the risk seems to drop down quite a bit too. So that's a nice thing that we like to see. Of course, some people do have persistent symptoms, but again, it's about getting in there quickly with the relapses, spotting them, assessing them, and treating them with things like steroids. These attacks tend to respond quite exquisitely to steroids. And so disability is quite uncommon if attacks are treated quickly. And overall, I hope my colleagues would agree that most people do well in the long term, and that's our job to keep you all well. So on that note, I will pass along to my colleague, Dr. Fink, to talk about diagnosis and treatment. Dr. Fink, I will end my show and let you share your screen so you're in control.
I will try. Yes, thank you. Would that be fine? I guess so. No, we don't see anything, right?
That's because I've just stopped sharing successfully.
You stopped sharing, okay.
Doesn't matter how many years of COVID we had, I'm still rubbish.
That's. What do you think? Does that look good?
I can see that really well.
Oh, perfect. Good. Great. So thank you for inviting me tonight. And I'm Katharina Fink. I'm a neurologist in Sweden, in Stockholm, based in Stockholm, and I see patients with MOGAD, but also all other neuroinflammatory diseases. And today I will talk about diagnosing, like our diagnostic criteria for MOGAD, and what kind of treatment we have available. So hopefully this is going to move. Not really. Let me see if that works this way. Here we go. Early on, MOGAD and also NMOSD were probably hiding within a MS cohort. So first, recently in 2023, as you see on this timeline, the first MOGAD diagnostic criteria were proposed. And one of the major features of being able to diagnose MOGAD is that we're able to detect mock antibodies, which started to be available on routine probably around, at least here in Sweden, around 2018, I guess earlier elsewhere in the world. But this is a quite busy slide, but I will try to walk you through. So to get a MOGAD diagnosis, you have to fulfill those three core features. And the first one is that you have to present with a demyelinating event like optic neuritis, myelitis, as we learned earlier in the previous presentation, or for example with ADEM or CCE. Further on, you have to have a positive mock IgG test that is often taken in blood, but can even be tested in cerebrospinal fluid. And one of the major features of this diagnostic criteria is that you have to exclude any better diagnosis, for example, multiple sclerosis, but also NMOS, as aquaporin 4 positive NMOSD. So to do this, we usually do blood samples. We ask to do an MRI of the brain and the spinal cord, and we do a spinal tap. And with those diagnostics are done to, on one side, exclude differential diagnosis, but also to collect the features that we need to fulfill those diagnostic criteria. So one of them is that we need the positive MOG test. And for that, we take serum, so we take blood, and we analyze the blood with a cell-based assay and look for mock antibodies. If you're clear positive, you don't need to collect any other of the features to fulfill those diagnostic criteria. But if you're low positive, or you're positive but nobody can report the titer, we have to fulfill other other features. You have to be aquaporin 4 IgG negative. We're not allowed to find those, and we have to find other supporting clinical or MRI features. So one other thing that is in those diagnostic criteria that's pretty interesting is that we can use the cerebrospinal fluid as well. If you have a negative serum test, and that can happen quite often, that we have negative serum tests, that we can't find the MOC antibodies in the serum, we can test the cerebrospinal fluid for positivity. And those MRI diagnostic features that we look for are, like, we look at the eyes on an MRI, and here are some of those pictures. A, B, and C show MRI pictures of the eye. You see the eyes. Do you see my cursor? No, maybe not. Yeah, you do that. Okay. And then you see the optic nerve as well. So we would look for bilateral optic nerve involvement at the same time. So we would have an enhancement on those two. We would look for longitudinal optic nerve involvement. So that's like the whole way, preferably from the eye bulb down to the chiasma. We would try to look for perineural optic sheath enhancement that we would see probably here the best on the picture B. And then we would could look also for optic disc edema that we could see here and there. But if you would do an fundoscopy, for example, an ophthalmologist looks into your eye, you could see those edema as well on the bottom of your eye. So further on, we would like to look at the pictures of your of the spinal cord, and here we would try to look for longitudinal involvement of the spinal cord, so longitudinal lesions. We would look for lesions, if there are lesions in the conus region, so the last part of the spinal cord, and we would look for central cord involvement, which is often shown as an H sign. So that is actually giving the name. It's funny, the same, the picture is also called H, but like here's the H that we're looking for. When looking at the brain, we would try to rule out that we have a picture of an MS picture, but we would try to look for if there's an involvement of the midbrain pons. We would get the cerebellum involvement if we could see deep gray matter involvement or huge lesions in the supratemporal parts of the brain, or cortical involvement, as we heard in CCE. We could have cortical involvement with even enhancement of enhancement there. So this is what we would look for when we would inspect the MRI. So all this together is going to give us the possibility to make an MOGAD diagnosis, but then what we do in treating this. So to treat, we would have the possibility to, in a relapse, to offer acute treatment with steroids, plasmapheresis, or immunoabsorption, or even IVIG. Mainly in kids, you would probably use, instead of plasmapheresis, you would use IVIG. That is for the relapse phase, but then if you have a patient that has presents with a second attack, so we would expect several phases of MOGAD, so a relapsing course. We would try to find a working maintenance treatment. The interesting thing here is to mention that classic disease-modifying drugs for MS are often ineffective, so it's very important to distinguish MOGAD from MS also out of the aspects of treating the MOGAD successfully. And then depending on what kind of symptoms you have, we would try to find the right symptomatic treatment. Presenting with seizures, we would try to find an anti-seizure medication, anti-spasticity treatment, rehab, physio, occupational therapy, or even involvement of other disciplines, especially urology and gastrology. If you have problems, or if you had lesions in the spinal cord, the lower part of the spinal cord, where symptoms of the bladder and the bowel have presented. So if I try to track out the treatments, we have the acute treatment where we would give corticosteroids, normally intravenously, methylprednisolone for 3 to 5 days, followed by oral prednisolone tapering, often 60 milligrams down to 20. And then there are 2 options, and I guess that's a bit depending on where we are in the world. And even here, if you think of Stockholm, we have several different hospitals and they have their different routines here. I guess there's nothing really written down how you're supposed to do it, but some would prefer to stop the treatment quite early to get rid of the prednisolone due to all the possible side effects, and rather have corticosteroids in the pocket and offer that as soon as you get if you would get a relapse, you could take it yourself until you'll be able to see your neurologist again, which is hopefully you could within like quite soon. Or some would prefer to continue for at least 6 months with a 20 milligram regime, and then try to retest if you lost your MOGAD positivity or your titer has gone down, you probably would start tapering and stop it. On the maintenance treatment side, that's probably offered after the second attack. You have like options of oral long-term prednisolone, which comes with quite some side effects. So you always try to find something that saves you using prednisolone, like corticosteroids, for example, methotrexate, azathioprine, mycophenolate. Those are used. All of them are all of our options are none of our options is perfectly designed for MOGAD so far. So we use them out of knowledge from other neuroinflammatory diseases. For example, rituximab has shown that it has some effect, but is not as effective as NMOSD, as it is in NMOSD or MS. IVIG, not continuous, but with a regular refill has been tried and has shown some effect. And even IL-6 antibodies, for example, tocilizumab, has shown to have effect. So currently, there are at least 2 substances in RCTs, satralizumab and rosanolixizumab. So those are ongoing, and we're awaiting the results. So the interesting part is when you treat that you can lose your positivity over time. Your antibody positivity for MOGAD can become negative. And also one interesting feature in MOGAD is that actually some of your MRI lesions can resolve over time. So that's also one of the interesting features with MOGAD. And I think I've come to the end of my presentation. So I give over to you, Silvia.
Thank you, Katharina.
And I try to stop sharing, right? Here we go.
Okay, and I try to share mine. Is it sharing?
It's not, but Sylvia, if you want me to manage your slides, I can.
Yeah, if you can kindly show my slides. Sorry, it's not.
Of course, don't worry. Let me just get them. Hold on one second.
Quickly jump in as well to say, if anybody has any questions, you can either use the chat feature at the bottom of the screen or the Q&A feature. So any questions about any of the presentations here, you can pop them in there.
Okay, I am firing up my screen. Everyone can just let me know if you can see it. See?
Yes.
Yep.
Yeah. Thank you very much. So, good evening, everyone, and thank you, Sumaira Foundation, for the invite. I'm Silvia Messina. I'm a consultant neurologist in the UK, Frimley Health NHS Foundation Trust, and I also work in Oxford University Hospital, in the clinical trial unit when I run clinical trials for MS, MOGAD, and NMOSD. Next. So, Dr. Fink already showed us like a very good timeline of what's happening and what happened in the field of demyelinating disease. And sorry, I think I see my first slide. Yeah, thank you. So we know that a lot of progress have been done over the years, and in particular, then next we can see that in 2009. So next slide is like, yeah, in 2009 we had the discovery of the MOG antibodies, and so we started understanding that actually this condition was different and separate from MS and NMOSD. Next. And then in 2023, we defined the MOGAD diagnostic criteria. Why these are very important, also from like clinical trial point of view, and we will see because we are discussing today also about clinical trial, we discuss about clinical trial. They are important because they give us the possibility to standardize like the diagnosis of MOGAD. Next. And where are we going? We are going towards MOGAD treatment because, as you know, there are currently no approved treatment for MOGAD. So we have to investigate in trying to find a treatment that is specific and tested for MOGAD patients. Next. And what does it mean, understanding MOGAD? It means understanding about the pathogenesis of the disease. So it means understanding what's happening, what are the mechanisms that are happening behind the symptoms. And we do that thanks to pathology study, to neuroimmunology study. We want to understand about the symptoms and how they appear in our investigation. So we use MRI studies, we use clinical studies. But our aim, our final aim, is to find a treatment. And thanks to like this combination of different type of research, we can then investigate and try different tools and different treatment. Next. And who are the people that are involved in understanding MOGAD? We have the doctors, definitely. Next. Then we have the scientists, the researchers that are helping us understanding the mechanism behind the symptoms that the doctors can detect. And then next, the most important actor in this understanding process are the people with the condition. So the patients, like all the discoveries, all the clinical discovery in this field, they all come from our clinical observation and what the people, the patients in clinic, tell us. Next. And now we focus on treatment, as I said before. Next. Sorry for this annoying next, but this is how it is. So Dr. Fink already discussed about different scenarios, so acute treatment, and next, is preventing relapses. And we know that next, we prevent relapses using chronic treatment that can be used long-term. So the relapse prevention treatment, they are not specifically approved or tested for MOGAD, but all the experience comes basically from an MOSD. So, and these are the treatments that are more commonly used. So prednisolone, especially in the first period after the onset attack, because we know that there is like a higher risk to have more relapses. So we cover with prednisolone initially after the onset attack and the acute treatment. Then we have azathioprine, mycophenolate, methotrexate, not really used lately, and then rituximab, that they can all be used in case we have a relapsing MOGAD. And then what happens when we have a relapse or the treatment is not, the patient's like is having like other attack. So we have to evaluate if we are on an adequate dose on immunosuppressant for an adequate time, and if they were, then we have to consider an alternative first-line treatment, or we can consider IVIG. There have been some studies showing that there have been some effect with the IVIG, however, again, not clinical trial, but like mostly clinical studies, observation. And then there is the possibility of clinical trials. And Dr. Fink already mentioned two are the current drug medication that have been tested, that are tested in this moment for MOGAD patients. So we have satralizumab and rozanolixizumab. Next. So this is like a cartoon that can be, it seems like a bit difficult to understand, but I'll try to go through that and explaining the most important point. So basically, let's focus on the MOGAD part. And you can see the B cells. The B cells are basically those cells that are normally producing antibodies. And these antibodies are the antibodies that we use to fight an infection. For the B cells to produce antibodies, they have to mature. They have to become able to produce these antibodies, and they have to become plasma cells. How do they become plasma cells? Thanks to a little help. So we have the lymphocyte helper, this is how it's called, that can give a signal to the B cells and ask the B cells to transform and produce antibodies. How this mechanism happens? Thanks to IL-6. IL-6 is like a messenger. So it's the message that the T helper sends to the B cells asking produce antibodies. It happens sometimes in autoimmune disease that the antibodies that are produced, they're not all good antibodies, but there can be some harmful antibodies. These antibodies, they cross a barrier and they arrive to the central nervous system, and they can cause damage, as we know. So in order to stop the damage, what we have to do, we have to attack this process from different points. So satralizumab, for example, is a medication that attacks the IL-6, so stop the messenger, while rozanolixizumab is a medication that acts reducing the harmful antibodies. So you can see from this cartoon the two different levels of mechanism of action. Next. And today we will discuss about the COSMOG clinical trial. So is the clinical trial to understand and to evaluate the efficacy of the rozanolixizumab. We discussed this clinical trial because it's actually run in both UK and Sweden. And today we have, of course, people from these two countries. So next. So why it is important during a clinical trial? So during a clinical trial, the scientists have to understand and have to test different disease and different condition. And what we want to do is to find like a treatment that can help people with this different condition. So when we do a research study or a clinical trial, we can see how this new treatment can work on participants. So the presence of the participant is essential. Like, no, not any discovery can be done if patients are not participating in research. So before a research study starts, basically like all the sponsor of the study, so the body that you can be a university, an institute, a research institute, or like a pharma company, the body that is organizing the clinical trial, they have to ask for a review to institutional review board and ethics committee. And once they have a review and we see that all the ethical standards are met, then the study can be started. So when a person starts a clinical trial, has the opportunity to help a very large number of patients with the same condition, with MOGAD. At the same time, you might have, and you will have, the possibility to do something that could be beneficial for your health. However, we always have to remember that it can happen that the clinical trial is not going to have an effect on your health, or can also make your health or your condition a bit worse. Next, but the most important point that we always have to remember is that your safety is paramount and is the most important point in every type of research, including participants and patients. And your health will be always monitored through the process of the clinical trials. Next. So a little bit of discussion now about how does it work, how we arrived to a clinical trial to understand if the treatment is okay and is like helping the people with the condition that we want to study. So now we are discussing, of course, about MOGAD and drug that can help patients with MOGAD. So every investigational drug needs to go through a different stage of research. So first of all, we have a phase 1 study. The phase 1 study is a small study where we actually include and enroll healthy volunteers. So it means people with no condition and not other comorbidities. In this study, what we try to understand is to see if this medication, this new medication that we want to test, is safe, is tolerable, and also we do some study to understand what's the good dose that can be used and then tested in a different population. So once the phase 1 study is done, we can go through a phase 2 study where we actually have and include the participant with the condition that we are studying. So in this case, MOGAD. So in this type of study, we usually have to compare this population of people with condition and treated with the medication, the active medication that we are studying, to a group of patients with no medication or with placebo. So placebo is basically very similar to the medication that we are studying, but there is no any active drug there. And we will see why this is important. Placebo, the words means I will please you. So I will give you something that is similarly to a drug, can do something good for you. But in reality, there is no drug. And this is very important when we have to compare the effect of the drugs. With this type of study of phase 2, we understand more about the side effect in the, of course, in the population with MOGAD, and we understand if the dose that we found in the phase 1 study is actually effective in the population that we are studying. Next. And then we go through the phase 3 study. The first phase 3 studies are even larger study. And in this case, we can compare with a placebo or with an active comparator. What does it mean, active comparator? For example, if in MS, we know that there are drugs that have been approved already. So if we wanted to test a new drug, we can compare, instead of comparing with the placebo, we can compare to a drug that has been already approved. Of course, it's not the case in MOGAD, because as we said, there are no treatments that have been approved so far. So the COSMOS study is a phase 3 study. And in this study, we have a larger population of patients with the condition. We understand more about the side effect. We understand if this treatment is actually effective. And then after one or more phase 3 studies have been run, the sponsor, so the body that is like running the study, they collect all the information, all the data, and they create a dossier that will be presented to the regulatory body. So the MHRA in the UK, the EMA in Europe, FDA in the US. So they present all this body of work and they ask for marketing authorization. If the regulatory body are happy with the information and with the safety profile and the efficacy profile, the drug becomes available like in the clinical practice. What happened next is a phase 4 study. They are called post-marketing study. In this case, the marketing approval have been obtained, so the drug can be monitored over time in a very large population. So all the people that are actually taking the drug in the clinical setting can be monitored, and we can monitor the effect long term. Next. So the COSMO is a phase 3 study, as I said before, and the aim is understanding how well tolerated and how effective is the administration of this new drug in people with MOGAD. As we said, there are no currently any treatment option for MOGAD, approved treatment option for MOGAD. So with the help of the participant, of course, we can see if this new medication can prolong the time in between relapses. Next. And as we were saying before, how this medication works. So I'll show you before like that cartoon, but just to go a little bit more in details, what happened in a condition like MOGAD is that these antibodies that are harmful, they're going to target myelin, and they can cause basically a swelling, an inflammation, where in the optic nerve, in the spinal cord, in the brain. When we have this drug, this new drug, the mechanism is actually to reduce the harmful antibody that are causing MOGAD. Next. And basically, when you are part of the clinical trial, if you decided to take part of the clinical trial, you will be assessed weekly for about 4 years. Most of these visits will happen at home, but initially, like for the first 4 weeks, the participant will be seen in the hospital because, of course, you will receive the drug for the first time. And of course, we don't know if you are on the drug or if you are not on the drug, but you will be monitored in the hospital. And then after that, after we know that the medication is safe, because remember, safety is always the most important part of a clinical trial, then the drug can be administered at home with a specialist nurse. Before starting a study, any study, we have to do a screening. So a screening means that we do a series of investigation, physical examination, neurological examination, eye exam, and MRI scan, and we will assess if you are fit for the study, because again, we have to be sure that there are no any other condition, there are no any other problems that can make your condition worse if you enter in the study. So next. And then once the study, the screening has been obtained, the patients can enter into the double-blind treatment period. So the double-blind treatment period is the actual treatment period. So the participant will receive the infusion, is a subcutaneous infusion, so under your skin, every week. As I said before, for the first 4 weeks, it will be in the hospital. And for the first 4 weeks, the participant will receive steroids. This is because to protect from the relapse until the full effect of the new drug has been achieved. The other important thing is that why it's called double blind, because I don't know if you're on treatment, on which treatment you are, and you don't know on which treatment you are. So we don't know if you are on the treatment or on the placebo. And that's very important for the success of a clinical trial. So for how long the participant needs to stay on this double-blind treatment period? If the participant has a relapse, then it will be switched in the next phase. If there is no relapse, then participant will stay in the treatment period until a total number of 58 relapses have been recorded across the participant all over the world in the study. While 58, this is like a statistical, a number that has been statistically developed. So the statistician, they understand and they study, and they see that this is the number that gives the power, enough power to do like a proper calculation of the efficacy of the medication. So this is why this number is coming from. And of course, if there is a relapse, if you have a relapse, like during the study, this will be treated as a clinical, like with the normal clinical management, so with the steroids. Next slide, please. And the open label, the extension phase, is the next phase. So in this phase, everyone will be on the active drug. So once the double-blind treatment period is ended, like the open label phase start. So again, in the open label phase, the first 4 weeks will be in the hospital, and then the drug can be also administered at home. If the person doesn't want to enter in the open label treatment phase, they can also ask to stop the study, and they will be seen 2 months after the last dose, just to check that everything is fine in terms of health. And then if the participant goes into the open label phase, it will stay on the open label phase until the study will be closed, and then the approval will be requested. An important thing is that everyone is free to leave the study at any time and at any moment for any reason. And this is not going to impact the clinical management, your clinical management. Next slide. This is just terminology. This is like the terms that we use across the presentation, just very quickly, because we already sort of described that and discussed that. Subcutaneous infusion, the infusion of this new medication is subcutaneous, or you will hear your doctor also say subcut. So it means that it is administered under your skin. And the amount of liquid is basically less than a teaspoon. And it's usually done within 30 minutes. And then we usually ask the participant to stay over for observation, especially at the beginning of the infusion. Placebo, we said it before, it's the comparator. And why it's important? For example, if you have a group of patients that are in the active drug and they developed and they describe a headache, and then you have the same percentage of patients complaining about headache in the placebo arm, yeah, that is why it's important, because we understand if there is the same percentage, that this is probably not related to the new medication that we are studying, but probably is just like similar to what happened like in the general population, because headache is quite a common symptom sometimes. And is also like a requirement in most of the clinical trial to have a comparator with a placebo. So what does it mean, randomized? Randomized, it means that by chance, the participant will receive either the active drug or the placebo. So, and the percentage usually 50%. So if a person decides to go to the clinical trial, 50% is the probability that you will be on the active drug. And open label, we said already, is when everyone is receiving the active treatment. Next. And what happens at every study visit? So every study visit has usually a different structure, but just to summarize, this is what we usually do when we see you in the clinic, or when we do an assessment in a clinical trial. We do blood samples, we do an ECG, we do an eye exam, MRI scan, a neurological examination, and a general examination. We give some questionnaire about fatigue, about quality of life. We review the side effect, so we record if there is any side effect. We check all the other medication you are on. We administer the study drug. We collect the urine sample, and we also record all the vital signs after you have your infusion. Another important point is that, of course, you don't have to pay for the study drug or for any related procedure. And basically, there will be a reimbursement for the expenses that are related to the study, like, for example, the travel expenses. Next. So who is going to be part of the study? So as we said before, we have to be sure that we are standardizing the way we include patients in a clinical trial, participant in a clinical trial. So the Colmo study is looking for about 100 people worldwide, and the age is between 18 and 89. Diagnosis confirmed of MOGAD with the 2023 criteria. Relapsing MOGAD with 1 relapse in the last year, and then positivity for MOG antibodies within the 6 months prior to the first dose. And then there are all other additional criteria that are more related to your general health. So we want to exclude that you have any possible condition that can affect your health during the clinical trials. Next. And are the clinical site in the UK. So Oxford University Hospital is I'm one of the investigators in the clinical trial unit, and Professor Pallas is the principal investigator. And then the Walton Centre in Liverpool, where the principal investigator is Dr. Huda, who is here with us. And then in Sweden, Stockholm, we have Dr. Katharina Fink, that she's also here with us, and she's the Cosmog site in Sweden. Next slide, it's a summary of all the contact details. So if you would like to have any more information about this clinical trial, you can visit the website. You can also contact the participating hospital. We are happy to discuss it with you. And you can also contact the UCB cares. So there are the email address and also telephone number. Thank you very much.
Great, thank you. You all for those presentations. We've had a few questions in the chat. I think we'll go straight to the Q&A because I'm aware we're a bit short on time. So the first one I had was, how regularly should MOG antibodies be tested, and can you confirm the chance of an attack happening if the antibodies are low or negative? And if so, what would be classed as low?
Saif,
Yeah, no, I'm happy to. Maybe Silvia, you can come in with recent
immunology.
Paddy's and Jackie and you guys that have done very recently. So I think everyone does things slightly differently in terms of the frequency of retesting. I tend to retest when clinic visits, and when we see people at least annually. Majority of the time, when people become negative, they generally tend to stay negative. But sometimes, occasionally, we do see people sero-revert back to positive serostatus. And so that's worth us knowing. And then very recently, there was a paper from the Oxford lab that came out that showed if the titers, the strength of the antibody detection in the blood shoots up significantly, then the chance of that being associated with the relapse is a little bit higher. Not in all cases, but in some cases. And so sometimes monitoring the levels can be useful for that reason too. Scott, so the question was about frequency of testing and levels. What was the other bit?
Yes, so what would be classed as a low level of antibodies?
Yeah. Depends on the assay that you're using. So in England, we use the live cell-based assay predominantly. For that, we take a human MOG and we express it in human embryonic kidney cells. These are live cells, human cells, and that allows MOG to be expressed in its natural state with all the sort of four-dimensional conformational properties. That 3D structure is really important. I think a bit like trying to insert a lock into a key into a lock. So the lock has to be correct. It's got to be the right shape, and all that sort of stuff has to work properly. So if you haven't got that conformation correct, the key won't fit, and that's how the MOG antibody fits into the MOG antigen. That's how we detect it. So with the fixed assay, sometimes you need a slightly higher titer to pick it up. And then there's different methodologies about how we detect the positivity. So sometimes we look down a microscope and we can grade the positivity. And then sometimes people use something called FACS, which is a way of cell sorting the positive cells from the negative cells. And then you can do that on a graph. You can quantitate based on however many cells you're looking at, how many of those are positive, how many of those are negative. You can get an intensity that you can of the signal of how positive it is. And based on the metric, how positive that is, that number, sometimes people use that number to tell them whether it's positive, negative, or low positive. But this is an important point because, particularly for the diagnostic criteria, as Dr. Fink has mentioned, low positive, we need additional clinical criteria and additional supporting criteria to make the diagnosis. For instance, with optic neuritis, just having the optic neuritis wouldn't be enough. You'd have to have some other features like swollen discs that we can see with an ophthalmoscope, like when you're at the opticians. We'd want to see some characteristic changes on the MRI. So the distinction between low positive and true positive is important, but it is assay dependent, and that varies from where you are in the world. Dr. Messina, would you like to add anything to that I might have missed, please?
Yeah, I want to just say that, yeah, we also used to monitor once a year when we see the patients in the clinic, similarly, like to repeat the antibody. And but if you are, like, for example, in a non-tertiary center, like I work also in a non-tertiary center, so I usually also suggest to repeat it. Like, of course, when the patient was negative and has new symptoms, it might be helpful to repeat the antibodies to see if actually there is a change, like if there is like a mild relapse, mild symptoms. It can be helpful sometimes to repeat the antibodies at that stage. Or, for example, if patients were negative and you have like a very high suspicion that patients could have been positive, then you repeat it when there are new symptoms. But in general, if we talk about monitoring, I agree, we do once a year, usually.
It's similar.
Also
here in
because it
Sweden.
makes us understand more
Yeah.
about the condition. Sorry.
Sorry. I think it's similar here in Sweden. But compared to that, you use the live cell-based assays. We do fixed cell-based assays. Just so we have to send that abroad to get a live cell assays.
Thank you. The next question again is something to do with like testing. So how do you differentiate between acute migraines and MOG? At the moment, I am being treated for migraines, but not MOG, which I have tested positive for.
Who want to answer?
Yeah, please. I took the last one. I'm happy to chip in after as well. Yeah, I don't want to hog the limelight.
So I can give my answer when I say migraine is like is a different condition. If it's migraine together with visual problems, then it can be associated like with MOGAD. I mean, not migraine, but we know that patients with an optic neuritis, for example, sometimes can present a pain that is very like migraine-like, but it doesn't mean that every migraine can be related to MOGAD. So of course, here we cannot discuss like specific case or specific picture, but I will say that, I mean, the migraine on its own, like it's not enough to say that this is like related to MOGAD. So we don't know, of course, the details of the case. I don't know if you wanted to add anything else, Katharina or Saif.
Yeah, I agree with what you said there. We do see migraines, and it's the most common thing I see in my general clinic. It's super common.
Yeah.
People who have migraine disease are going to, by chance, also have migraines as well. Sometimes we see after optic neuritis, people develop headache syndromes. That there's anatomical basis to postulate as to why that may be. And for sure, people with MOGAD disease who've had optic neuritis can get eye pain afterwards. There isn't an optic neuritis attack, particularly when they're unwell, so-called recapitulation, a rundown, the body's ability to mask the symptoms that we normally don't notice isn't as good. And so sometimes those symptoms can creep back, and that's the case for any type of previous MOGAD attack. We could be manifesting with increased numbness or increased weakness. But the key is that it's transient, it comes and goes, and it's fluctuating, it's not persistent, evolving, worsening over 24 hours, and it's not associated with infections and things like that, which need to be treated. These things can mimic MOGAD attacks, and migraine is a mimic as well because of the visual symptoms that can come with it. down to the neurologist that's usually to take the story, to examine, ensure there's no disc swelling there, if necessary. A very helpful thing is the OCT, the laser scan of the eye that can look for any swelling of the optic disc to complement the visual testing that we have with our ophthalmoscope. And then, of course, there's MRI that can further differentiate in uncertain cases. It can be tricky sometimes as well. Remember that just because the MOGAD antibodies are there doesn't mean that an attack is definite. Plenty of people will have persistent antibody without further episodes. So it's not a definite either. But it can be unsettling, and I certainly recommend, without giving individualized advice, with uncertainty, if you're not sure, then do speak to your primary carer or your neurologist about it.
Okay, thank you. The next question I have is related to the clinical trial. Would someone having AVN stop them from being on the trial? And AVN being, I believe, a vascular necrosis?
Sorry? Can you repeat? Sorry, I didn't get.
So, would someone having AVN stop them from being a participant on the trial? AVN, I believe, is a vascular necrosis.
Oh, okay. So it depends. Of course, we have to understand if there is any risk of infection, and if there is any risk for for the condition, for the health. And this is like what we use. Oh, okay, a vascular necrosis. I saw that now in the. So it's an avascular necrosis that it happens after treatment with steroids. So it's not a contraindication, but of course, if in general, like if there is any need for steroids, we know that there might be a risk, but it's not a contraindication in itself. But every condition that can sort of cause any increased risk of infection, for example, it's usually a contraindication, or other autoimmune condition can be usually contraindication. So these are usually the criteria that we look at when we have to do like a screening. And if there is anything that can put like a risk the health of the participant, of course, it's then a discussion based on clinical basis and based also on the clinical judgment. So we usually consider if this is a condition that can affect the future assessment and the health of the person.
Sometimes avascular necrosis requires surgery as well, so it does depend on the severity of it. Often precipitated by steroids, and tapering the steroids in this trial is probably a helpful thing, but with any pre-existing medical condition, it's not a strict exclusion criteria, as Dr. Messina said, but probably worth one that requires further thought and discussion. Sometimes when there's tricky instances like that, there's a medical expert within the trial that we sometimes discuss those cases with as part of the scientific committee, just to be sure. Because things that can affect the ability to walk can impact, the way we assess the impact. It may look like a relapse, it's not, so things like that to consider.
Okay, great, thank you. Next one I have that's in the chat. Is IVIG a good treatment for MOGAD?
I think Dr. Fink.
No, I can try. I mean, there are the observational studies showing that IVIG should work. So as Dr. Messina mentioned, there is no clinical randomized clinical trial out. So we don't have the evidence as like from a randomized clinical trial, but observational studies show definitely that there should be some good effects of IVIG. I guess it's a bit of a question how to dose and when to retreat, what kind of procedure. And I guess that is a little bit also depending what kind of site and which center you're going at, what they prefer. But in general, I think it is used as one of the treatments to treat MOGAD, as one of the options to do that. Yes.
Yeah, great. And then a question I have in the Q&A, what evidence is there for MOGAD being triggered by certain vaccines?
Good question. Who wants to answer?
It's a very interesting question. So Anna Francis, who is in Oxford, we wrote up a series of cases that we would say were associated as opposed to caused by. There was a sort of close temporal association in terms of timing of the onset of MOGAD and COVID vaccines. But when we look at it on a population level, it doesn't reach significance. Though these studies are useful from an observational perspective to highlight potential things that are useful for scientific exploration, I wouldn't say that they would imply causation. For sure, what we see is more. In fact, probably some papers report up to 50% of MOGAD cases are associated with infection. At that kind of level, so much more than the hit rates that we hear about for vaccination. I'm not saying it's not possible. I think we need to do work in it, lab work to look into it. But my recommendation is to vaccinate, just because what we have seen is that the infection seems to be associated. Again, I use the word association because I can't say for sure it causes it, but is associated with the onset of COVID. So the onset of COVID, the onset of MOGAD. I also keep saying MOGAD and MOGAD, so I don't know. It's that time of night. What do you got? Do you say MOGAD or MOGAD?
MOGAD.
MOGAD. MOGAD.
Yeah.
I think it's, yeah.
I switch between them.
Yes.
Good. Yeah, I definitely think it's an interesting area that needs a bit of looking into further. It is hard to study in a lab. I think there should be a concerted effort to do that, because, I mean, the EBV story about this in multiple sclerosis. EBV has been circulating in the news stories for decades with multiple sclerosis, and people always go, another EBV. It's not really a thing. And then 2-3 years ago, there was a huge study done based on veterans in the US, which had the ability with blood sampling over time to show that people who had EBV, Epstein-Barr virus infection exposure, there was a nice link that they could prove sort of causality, and they did that with some lab experiments as well. And to finally show that EBV is a putative cause for multiple sclerosis. And of course, it's a little bit, it's not easy, but it's easier with more common disease. But it has been done. So I think that we should follow suit. Just like we're following suit with NMO to get good drugs and MOGAD, we should follow suit in terms of understanding the neurobiology as much as we can do.
And what I wanted to add is that usually is not the vaccine itself that is causing the MOGAD, but can be like a trigger in an immune system that is already predisposed for autoimmunity. So we know that like person with autoimmune condition, including MOGAD, there might be already some changes, like a predisposition in the immune system being more active. And then, like as a consequence, it is possible that sometimes, in some cases, like a vaccine can sort of trigger an inflammation. But this does not mean that every person having a vaccine, not everyone has an autoimmune condition, and not everyone will develop like an inflammation. So it means that there might be another factor that is active on that. So this means like vaccination is still something that needs to be promoted.
Great, thank you. That's all the questions we have from the chat and Q&A. Double check. Yeah. That's it. Yes, and thank you all for taking time out of your evening to share that information with us. It was very useful. Enjoyed it a lot and learned it a lot as always. Thank you.
Thanks, Sumaira, and sponsors too.
Yes,
Thank you.
a very enlightening conversation, lots to take away and think about. But for anyone here who's live, this will be available on our YouTube channel. But definitely feel free to reach out to the foundation, reach out to Scott or any of us if you have any questions. I always say that if I was eligible for a clinical trial, I would be signed up yesterday. You get VIP treatment, you get the best of the best care, and you're also doing something and contributing to something that's bigger than yourself. So hopefully the availability and accessibility of therapies for MOGAD patients around the world. So thank you all so much for joining us today. And I hope that this was helpful and useful to all. Have a good night.
Thanks.
Thank you.
Thank you.
Bye.